She told me to shorten it. Actually, I got you guys are really lucky because I got multiple text messages saying we're running out of time. All right, how do we do this here? Slideshow. Beginning. Okay. Well, thank you, and at residency, everyone did a great job. Dr. Jalan as well, and thank you to all the hosts, people who did all the prep work. We're going to talk today is what I call thyroid eye disease, the new frontier, and luckily I took off about 50 slides because Deb said to cut it short. So I know I worked really hard and didn't see my children for a week or so. No, I'm just kidding. Okay, so what we're going to do quickly is we're going to review thyroid eye disease, just briefly, the background, what we know into this point, what treatments we've done, and then go what's next and what's the new frontier. I have no disclosures to give you. Hey, just to review, here's just a great picture of a patient with a classic eyelid retraction, kind of those bugging eyes, injection. And as you can see, obviously, someone who wakes up or has a change over a year or two, it's definitely affects them not only with their vision, but also just with their confidence and their appearance, which is there's a psychological component as well. So we have to keep that in mind with these patients. Here's more severe disease, and this patient also has other medical conditions which may affect as well, but you can see more injected, more angry looking, and the asymmetry of the disease as well. Just some clinical findings we all know, and you don't necessarily have to have them all in order, or you can have bits and pieces, and it can be symmetric, asymmetric, but proptosis, eyelid retraction, cornea exposure, diplopia, neuropathy, inflammation, pain, and we also discussed the psychological components. So how do we get here? What's going on with Graves' disease? So what's the pathogenesis? There are autoantibodies that react to one or more antigens, and they're shared by both the thyroid and the orbit. Remember, you can have euthyroid Graves. Obviously, the most common is hyperthyroid, about 90% of them, but it can also be hypothyroid as well. Once these orbital antigens are recognized, you get a cascade of events, and it leads to the release of cytokines. These cytokines then cause trouble. There's activation of fibroblasts, expansion of orbital fat tissue, secretion of hydrophilic glycosaminoglycans, and immune attack on the extraocular muscles. Cytokines are immunoregulatory. They're produced by T lymphocytes. There are both Th1 and Th2 cytokines. Th1 cytokines are T helper cells, interleukin 2, TNF alpha and beta, and interferon gamma. And then Th2 cytokines make up IL-4 to 5 and 6 and 10. These fibroblasts are neural crest origin. There's a CD4 surface marker, and they're activated by T lymphocytes. So the activated fibroblasts, they're pre-adipocytes that go to adipocyte tissue with the TSH receptor, and they're obviously influenced by the TSH. We have increased orbital fat volume from these increased adipocytes. We have hypertrophy of the adipocytes from the TSH, and the increase in glycosaminoglycans, which we see edema in the tissue. Regarding the muscles, there's enlargement by passive fibroblast activity. You get edema of the connective tissue. There's actually no muscle disruption, and there's the increase in the glycosaminoglycans between the muscle fibers. And here's just a classic CT, axial and coronal, demonstrating enlargement of the extraocular muscles. In a typical fashion, we all know that most common is going from inferior rectus, medial rectus, superior rectus, and lateral rectus, and that I'm so lazy mnemonic that we all know so well. And you can see here with these enlarged muscles that we're worried about in this case would be compressive neuropathy. Obviously, patients may have diplopia as well. That's if the muscle is involved. So extraocular muscle disruption from T cell reaction to these antigens. And now we're going to just move on to pathogenesis. We have population risk, environmental risk. We all know the significance in the connection with smoking in this population. Fibroblast stimulation and extraocular muscle disruption. Fibroblasts associated with Th2, TSH receptor, and increased orbital fat. And extraocular muscles have these shared antigens, and there's confusion between the fibroblasts and the extraocular muscle antigens. Again, clinical findings that we reviewed before. Here's a patient with proptosis and some lid retraction, obviously more severe disease, proptosis, inflammation. Some of this is from just exposure keratopathy. We'll have to call Dr. Cam to come in to take care of this, and Dr. Gilmore in the future as well, these two guys. So severe disease, that's an unfortunate case. That last one was a pediatric case of Graves' disease. Just a brief background, as you all know from here, at least from my background, is that I like to classify Graves' disease into two types that were described by Nunnery in the late 80s. And these are clinical observations supplement with immunological investigations. These are two separate subtypes, but they overlap and they're different. So basically, just briefly, it's type 1 and type 2 disease. With Graves' disease, type 1 is no restricted diplopia, whereas type 2 is restricted diplopia within 20 degrees of fixation. Recently, or in the past couple of years, I'm thinking more inflammatory. I kind of divide it, are they inflamed or not? And it's just, there's these two diseases are associated with smoking in both groups, obviously more in the type 2 groups, but they're dual theory of pathogenesis. It's not like you go from 1 to 2. They have different prognoses. There's different populations and different pathogenesis. The type 1 disease, there's no restrictive myopathy, it's bilateral proptosis, eyelid retraction, they're symmetric typically, there's no inflammation, there's increased orbital volume due to the fat, maybe the muscles are swollen, but not like that thick scarred muscle tissue that we see in the type 2 degrees. Here's a patient, lid retraction, proptosis, again, another patient with no diplopia in all fields of gaze. And these patients have exposures, they can have superior limbic keratitis, phlegophthalmos, they have cosmetic issues, but there's really no neuropathy, no chemosis or inflammation. Here's just some staining typically, like all the cornea people look at that and describe that. But some dry eye symptoms from keratopathy, more severe exposure, again, superior limbic keratitis. So these type 1 patients are symmetric, and they may even have severe proptosis, but remember, they're not at risk for having any compressive neuropathy or diplopia. So Nunnery et al. Reviewed about 124 patients, divided 65 type 1, 59 type 2. And the type 1 group, the range of Hertels measured a range from 16 to 34 millimeters with a mean of 20.1.8, not so much asymmetry. In this population, more females, 82% females compared to males, but there's a wide range. The average age was about mid-30s. Here you can see in the CAT scan, there's increased orbital volume from the fat tissue, but really not so much muscle enlargement. Again, here you see that as well. Tendons are spared, muscles enlarged, but it's not that significant. There's orbital fibroblast stimulation in this population, the Th2 cytokines, lymphocytes, we have the thyroid antibodies and insulin growth factors, all these things happening. Orbital fibroblast stimulation without myositis, remember, there's passive swelling of the muscles, but there's some circulatory factors going. Compared to our type 2 disease, which is really the ones that are the tough ones to treat. They have restricted myopathy, asymmetry, inflammation, and most importantly, they're at risk for compressive neuropathy, chemosis, extraocular myositis. Here's a patient from my fellowship. She's got asymmetric proptosis. You can see the strabismus, and she actually, even though the right side is the less proptized side, you can see here why the right side is the one with the neuropathy. You can see the compressive component there in those large muscles. This group, still more common in women, but not like the first group, higher age of average, about 52, and these patients are slightly more proptotic and more asymmetry is the key here. Again, that patient from before with enlargement of the muscles, leading to that higher incidence of compressive neuropathy, at least in this series, with the type 2 patient compared to type 1, 36%. These type 2 patients, the local or systemic immune process, it's targeting that extraocular muscles, different receptors, and again, the cytokine response. There's extraocular muscle disruption in this group, whether it's mitochondria, sarcoplasmic reticulum, there's loss of striations. So let's just move on to treatment, and I know we're running out of time. So going from very basic disease and basic treatments, we always start off with the most conservative management, whether it's lubrication, taping the eye shut, obviously controlling thyroid function, stopping smoking, going on selenium, different things. Immunosuppression from either steroids or steroid-sparing agents, radiation, surgery, obviously, and then what else? What's the next frontier? So just a brief background. You know, if you had asked me 6 months, more than 6, let's say last fall, what would we do for a patient? I think we were moving towards steroids, but steroids in a different fashion. I started moving towards IV steroid treatments. You know, 6 weeks, even up to 12 weeks of pulse steroids, a gram, not a gram, about 500 for the first 6 weeks, and then 250. Some people doing a little higher. Good data with that versus doing oral therapy. Other steroid-sparing agents in the past. Again, nothing here has been approved. It's not specific for Graves. We're just taking things so we don't have to give steroids, whether it's cyclosporin, methotrexate, rituximab, and then other anti-cytokines. Steroids are high doses or usually short-term. not really for non-inflamed type 1 patients, usually to shorten acute attack or for preoperative neuropathy, or if you have a flare-up postoperatively. And then other immuno agents for those diabetics or glaucoma patients that can't really go on steroids, whether it's methotrexate, rituximab, and it's more for long-term if you need to do long-term treatment. An example might have been for a cytokine treatment, anti-TNF like Remicade, it's IV infusions, it's expensive. Obviously, it's being used for other medical conditions. It's not really for Graves, but we would use it for a type 2 patient who has that inflammatory component. And then, of course, the idea of what's radiation, big debate with this. I think for the most part, at least in my practice, radiation was like a last resort. Not great outcomes. Obviously, worry patients with diabetic or other retinopathy issues or chemotherapy that their retinas would be affected or their optic nerves. And these patients, maybe they had some reduction in proptosis, maybe they had improvement in neuropathy, but most of these patients still needed surgery afterwards. And maybe it was like I said, an adjunct to decompression or for recurrent disease where you just couldn't do any surgery or have anything else to offer. When we move on to surgery, we kind of go in order: orbital decompression, strabismus surgery, lid surgery. Surgery has really evolved over the past 20, 30 years. At the point where we're doing customized decompressions, figuring out what's the best for that patient. Not everyone's exactly the same, whether you're doing a floor medial wall decompression, deep lateral wall decompression, a combined balance between lateral medial wall decompression or three-wall decompression, or if you're just doing fat decompression. So a lot of options out there. Patients do well with it, but again, it's surgery, and it's not always going to take care of certain things. Because the biggest thing I think bothers a lot of patients is that double vision, which has to do with that disease in the muscle, and that's actually one of the hardest things to treat. So here's just a patient who's standard decompression, two-wall decompression, moving the floor medial wall. Obviously, you can see the improvement there. I just gave you one example there. So orbital decompression we used for classically for proptosis, neuropathy, exposure keratopathy, obviously cosmetics as well, cosmesis. But there's that risk of diplopia, vision loss, intracranial or orbital risk, as we discussed. Okay, so just going on to the new frontier. So I said, if you asked me in the fall what we would have done, we would have thought about steroids and surgery. And now we have this new exciting thing that finally is coming out on the market after phase 3 trial, which will be the first drug that was FDA approved for Graves' disease. So it's a new thing. Now, obviously, it's a specific population in trials, and now it's out there, and we can use it for different things. I was hoping when I signed up for this talk to give you some data, but due to COVID pandemic, we ended up not enrolling a lot of patients into the center here. So teprotumumab, which now is called Tepezza, there was a study that came out in January in New England Journal. Very important, just a background here. We spoke earlier about the different criteria, different signs of Graves' disease. There's really that's not really the best classification system. Now, the most commonly accepted is the clinical activity score, where in the first visit, you may have 7 things here listed: orbital pain, gaze-evoked orbital pain, eyelid swelling, eyelid erythema, conjunctival redness, chemosis, inflammation in the kernicterus and the plica. That's your first visit. Following the follow-up visit, you could have increased proptosis, decreased in the movements leading to double vision, and then obviously drop in vision, giving us a total of 10. And that's how they're kind of scoring this. So in the study that came out in January, they were looking at patients with moderate disease. And these were patients who had no treatment within 8 months. So no steroid surgery, nothing like that, just new disease Graves, and they were put in a trial. This is a good example of translational research with investigators who had initially demonstrated a role for insulin-like growth factor 1 in the pathogenesis of thyroid eye disease. And it showed that an antibody to the receptor produced a meaningful improvement in 83% of their patients. So they initially had 107 patients, ended up having 83 enrolled in trial. They split these in 2 different groups. One group got the placebo, one group got the drug. Basically, it's an infusion, 8 infusions total, 1 every 3 weeks. And by the end of the 24 weeks, they actually showed a significant improvement in the patients who received the drug compared to the patients who did not. And their overall outcomes that we were looking at was reduction in proptosis and also reduction in double vision. So different things that you can see here at the bottom of this nice slide is the primary outcome response to 24 weeks. 83% of patients treated with teprotumumab had an improvement in their proptosis compared to 10% placebo. Another significant thing was their clinical activity score was basically in 59% of the patients was 0 to 1 in the drug group compared to the placebo of 21%. And the last thing about the double vision improvement. You can see a comparison of 29% to 68% in the drug group, and then the mean change in the Graves' orbitopathy quality of life score was much improved in that group as well. Here's just some nice graphs demonstrating the same thing here. Top left, reduction of proptosis going to a change from the baseline. You can see that's significant here, and all this stuff is clinically significant. And same thing with clinical activity score. You can see that it's just remarkable in this population. And you know, they did compare. We'll see in a few slides that they did compare apples to apples. I mean, the groups are pretty similar based on race, age, demographics, amount of proptosis, and so forth. Here's a nice picture demonstrating the improvement. The first picture is patients on placebo, really no change after 24 weeks, but then significant change in the drug group after 24 weeks, reduction of proptosis, inflammation. It's pretty remarkable. And even more significantly, when they did an MRI, you can see in the image on the bottom left, the inferior rectus is inflamed, it's swollen, it's enhanced, and compared to the smaller inferior rectus just 24 weeks later. I was hoping to have my own patient data, but I don't have any yet. Okay, so just showing you that you're kind of comparing apples to apples. It's pretty close, I think. The comparison of the males to females, the age of the patients, very roughly close, and also the demographics as well. So one thing when it comes to drugs, you have to think about what are the side effects. So in both groups, there were only 2 patients that dropped out of each arm. So it's really not too terrible. The most common side effect is muscle spasms, and most people tolerate it. You can, of course, have side effects during treatment. So during the actual treatment, you can get a reaction just like anything else. Typically, they'll give you either a Benadryl or steroid or Tylenol to help with that. They can pre-treat it, but obviously most people completed the study. Another interesting side effects, dysgeusia, that you see with other chemotherapy drugs, is loss of taste. Typically, patients got their taste back a few weeks after treatment, so that's obviously a big thing for people. People like to eat. And then just other typical side effects. There are some warnings here. Obviously, we talked about those infusion reactions where you need to go and get treated with hydration and those drugs and so forth. For patients who are diabetics or prone to hyperglycemia, they are at high risk of hyperglycemia. 2/3 of these patients were diabetics. Patients who have inflammatory bowel disease might not be good candidates because I think they can have flare-ups. And then also in the female population who might be wanting to get pregnant, who are pregnant, they need to have proper contraception and then wait 6 months afterwards before going on this drug, or vice versa, or getting pregnant. So there's an autoantibody activation of the insulin growth factor 1 receptor that drives the pathophysiology of the TED. And we talked about that IGF-1R receptor is overexpressed, and that leads to those activation of orbital fibroblasts and whole cytokine cascade and everything that we see in this terrible disease. But luckily, this new drug, it brings us hope for the new frontier. Teprotumumab binds to the receptor, and it can block this cascade. In fact, if you speak to the people who ran the trial, they say that after the first treatment, you start to see kind of the disease stop. And by even the second treatment, you'll start to see improvement and reversal of disease. Now, I haven't seen that yet. I only have 1 patient doing it, and I can't say for sure, but we'll have to wait and see. Remember, it's a specific population. They didn't have any other treatments. The only patient I have on it so far has already, years ago, we did decompression, steroids, things like that, and this was kind of to help. So in conclusion, or some conclusions, TED is a serious and progressive vision-threatening disease. Among patients with active thyroid eye disease, teprotumumab resulted in better outcomes with respect to proptosis, clinical activity score, diplopia, quality of life compared to the placebo. Serious side effects were uncommon. Teprotumumab is the only FDA-approved drug for TED. Teprotumumab is a fully human monoclonal antibody that blocks the IgG1R, a key mediator in TED. The treatment decreased proptosis, an average about 2.5 in this population that were studied, resolves diplopia, reduces orbital pain, swelling, and redness, improves vision and appearance. It's well tolerated. Remember, 8 infusions as well. Currently trying to screen patients and enrolling them if they're appropriate. And thank you for allowing me to talk. Sorry that I went over 5 minutes.
Okay, Jason, 2 questions. Is there a cost analysis to PISA versus like surgical options, decompression versus traditional surgery?
Okay, so good question. Obviously, First, we know surgery at times will work, especially in a non-inflamed patient. Surgery, you're going to have expenses of time off from work, surgical actual, cost of surgery, hospitalization, anesthesia, all those things, versus drug. The drug is very expensive. I don't have an exact dollar. Right now, it's FDA approved, and we're kind of they're going beyond what was studied in terms of how which patients should get it. So it's a matter of getting it approved. Again, I have no disclosures, but basically, with the way it works for private insurances, the company is able to help supplement the cost to the patient. For patients who are on government insurances like Medicare, there are foundations that will help pay for it. So basically, the insurance company and these other resources will pick it up. As far as I know, no patient has to have any out-of-pocket cost at this point, luckily. So we'll see what happens. I mean, I don't know the exact number. I'm assuming it's thousands and thousands and thousands of dollars. But this is surgery is sort of putting a Band-Aid on things, and people, if this can reverse it, for those patients who have severe strabismus and they can't get by, I think it will be helpful. So.
Okay, and Kimball is asking, is it for type 1 versus type 2?
It's a good question. They didn't study it. My feeling is that it's good for active disease, type 2 disease. However, there are the people, again, who are kind of pushing the drug from who have more experience with it. They're using it basically on everyone. So my thinking is if you're inflamed, use it. It's better than steroids potentially. It's better than any of these other drugs out there. So obviously we give the option to the patient. I think in an acute setting, someone's losing vision, you're going to do what you can do. It might be surgery, steroids, and this. We don't really know. In a type 1 patient who has got some little proptosis, liver retraction, not inflamed, you could offer this. Obviously, it's very expensive. I think surgery might be cheaper at that point, and I don't know side effects. Now, with interesting things here, and I'll make a comment and I'll stop, is with the pandemic, as I said, I had about a dozen patients I was hoping to start this and then have some information for you. But then we had COVID-19, and I pushed it off because I wasn't sure with this biologic what it would do to the patient in terms of risk if they got COVID-19. Now, the interesting question, if you may remember, at the beginning of this pandemic, they were thinking about what drugs would work. They're actually looking at some drugs that were like this, that were kind of, I forgot the name, it also starts with T. It's very similar, that works with one of these receptors, and they were looking at it as a potential treatment of it. So even though this is a biologic, it's a steroid-sparing agent, the question is, would you actually be protected if you got COVID-19? And that's an interesting question with this, because it's not the same. It's not like a methotrexate or one of these other medications, or Remicade, where it actually will alter your immune system. So I was initially very reticent to give this to anyone, and I spoke to many experts in the field, and they basically said, well, we can't tell you 100%. However, this was used in, I think, about 700 or 800 cancer patients as a cancer the 50 patients who were in this multiple studies, and they found that none of these patients experienced immunosuppression during their time of being on the medication. So a lot of people were still using it just because it works a different way. Obviously, that's not 100%, but I hope that answers your question. But for me, I'm not using this in a patient who I think is type 1 disease. Now, again, people in the study, they were not treated with steroids or anything like that. So now I'm seeing patients who have had previous treatments, previous decompression, previous steroids, radiation, doesn't matter. I'm giving this in as an option if they're willing to go through it and they want to do it. We're trying it. Why not? If we can get it approved versus jumping into surgery. So if you're very proptotic, you still may need this surgery later. I don't know, but it's definitely a good option. I think it works the best for that severe strabismus. Well, that's really the hardest thing to treat with this disease. So, and obviously neuropathy as well. All right. Thank you.
Thank you. Thanks, everyone, for joining.
Amity, just real quickly, this is John. I just want to congratulate all of the speakers, the residents, and the faculty, and you as well for keeping things on time, and of course, Ms. Kephart for keeping things moving along, and today Jeremy was helping as well.